Do you know that what is the most common cause for seizures in the newborns? Do you know that what is the most common type of neonatal seizures? Do you know that what is the most common drug treatment for newborn seizures? And do you know what is the most common initial investigation of choice for newborn seizures? If you don't know and want the answers are right here. A very warm welcome to the medical channel, which is the world of pediatrics, public health and epidemiology simplified. I'm Dr. Sayed Kazmi, and today I will be presenting to you the theoretical and practical aspects of neonatal seizures. Neonatal seizures or neonatal convulsions, as some people call it, is one of the most distinctive feature of neurological disease or neurological problems in the newborn. And we call it as one of the most common neurological emergencies of the newborns. The incidence is 0.5 to 0.8% in the term neonates, while the incidence is relatively higher when we talk about the preterm neonates because of their neuronal immaturity. The incidence is of 5 to 15%. It's also very important to recognize these seizures because most of the seizures in the neonatal period can be very subtle, so it might be very hard to pick them up clinically. So it's important to understand the different patterns of these seizures in newborn so you can visually pick them up. And it's also important at the same time to find the cause, because there is a myriad of different conditions which can cause these neonatal seizures, and it's just like a sort of a detective hunt to look for the reasons or the etiology. And then at the same time, it's also very important to treat the seizures, because if you don't treat them, the long-term outcomes in terms of neurological morbidity is quite high. Now, moving on, as far as the causes of neonatal seizures are concerned, there is, as I told, there's a myriad of different conditions that can cause neonatal seizures. By and large, the most important is birth asphyxia. So birth asphyxia means a chain of events that leads to poor blood supply, or in other words, poor oxygen supply to the fetal brain, which usually occurs at around the time of childbirth. And it can happen because of a variety of different conditions. It can happen because of prolonged labor, it can happen because of placental problems, it can happen because of neonatal problems, or it could be because of the equipment used at the time of birth. So different reasons, but the eventual outcome of all these events is that the brain gets less oxygen, and since the brain neurons are very sensitive to if there is a lack of oxygen, so they die, they get damaged, and that would lead to seizures in newborns. So around 40 to 50% of the neonatal seizures are caused by birth asphyxia. They usually lead to two types of events. In premature newborns, it usually leads to intraventricular hemorrhage, IVH, and there are different types of IVH. Rather, I would say there are different grades of intraventricular hemorrhage. They are graded from grade 1 to grade 4. I would come to that later on. But intraventricular hemorrhage is one of the most common complication of birth asphyxia in preterm neonates, and that usually presents with neonatal seizures. In term infants, it can present with intracranial hemorrhage, which could be subdural hemorrhage or subarachnoid hemorrhage or intracranial hemorrhage, frank intracranial hemorrhage. That's usually more common in term as compared to the preterm kids. But remember, around 40 to 50% of the neonatal seizures can be attributed to birth asphyxia. Then the second group of disorders which can cause neonatal seizures are metabolic causes. There is again a big list of metabolic problems that can cause neonatal seizures, but the treatable one and the easy one that can be picked up by a simple blood gas is hypoglycemia and hypocalcemia. So a low blood sugar level or a low blood calcium level is very easy to pick on a simple heel prick blood gas, and it's easily treatable at the same time. While some of the electrolyte imbalances like hyponatremia, because again, hyponatremia itself is not a disease, it's usually a consequence of so many other things going on at the body, inside the body, that can also cause neonatal seizures. And obviously there is a big list of inborn errors of metabolism where there is problem in working of different enzymes, and that can lead to accumulation of different toxic substrates, which can lead to neonatal seizures. Again, that's a big list. I'm not going to go into the detail of that. Just remember, there's a big list of inborn errors of metabolism that can be responsible as a metabolic cause for neonatal seizures. Infections themselves, because infections also destroy the neurons, they damage the neurons, they can cause neonatal seizures. And again, infections can be acquired in utero. Most of the torch infections like toxoplasmosis, cytomegalovirus, congenital rubella, even Zika virus and HIV, they can cause damage to the brain, sometimes leading to calcification. And when that baby is born, he can present with neonatal seizures, or the infections could be acquired. So like early onset neonatal sepsis or late onset neonatal sepsis leading to meningitis, which is infection of the meninges, or encephalitis, which is usually viral generation. These can cause neonatal seizures as well. And last but not the least, structural brain problems, where there is a defect inside the brain, an anatomical defect, like there could be aneurysms which can rupture and can cause intracranial hemorrhage, or there could be neuronal migration defects, cortical migration defects as we call them, lysencephaly, holoprosencephaly, schizencephaly, and so on and so forth. These types of neuronal anatomical problems or cranial anatomical problems can give rise to neonatal seizures. So these are some of the important ones. There are others as well, but you don't need to remember because the list is such a big one that's not physically possible to remember each and every one of them. Some of the common ones you do need to understand, you do need to recognize that, because they are easily treatable, while the others usually even if you pick them up, they cannot be treated even with advanced medication. I think the prognosis is usually poor. But again, for exam point of view, it's very important that you should not be missing hypoxic ischemic encephalopathy, you should not be missing hypoglycemia and hypocalcemia, and you should not be missing infections. This is very, very important. Now moving on to the types of neonatal seizures. And type of neonatal seizures depend whether you see clinical seizures, whether you pick them on EEG, or whether the seizures are clinical as well as present on EEG. So in general, you can have clinical seizures where the seizures are only present clinically, or you can have seizures which are only present on EEG but they're not present clinically, or you can have seizures which are present clinically as well as on EEG. So this is the classification of neonatal seizures. When it comes down to the clinical forms of neonatal seizures, whether that is associated with EEG changes or not associated with EEG changes, remember there are 4 types which you must remember. The first and the foremost are subtle seizures. Now these are one of the most common seizures in newborn. The reason that most of the seizures in newborn are subtle is because the neurons are very immature. So the neurons have got less synapses in a newborn brain. So it's not very common for the seizure activity, which is an abnormal stimulation, that it would spread to other parts of the brain. So usually these are very subtle because they are affecting a small part of the brain, and they can be patchy in different parts of the brain depending on the areas which have been damaged either by infection or by the hypoxic ischemic encephalopathy or by substrate deficiency, like in case of hypoglycemia and hypocalcemia. So the subtle seizures are usually in the form of very subtle movements. So they can be in the form of vague movements, of abnormal movements of the upper limbs or the lower limbs. So movements like cycling or movements like swimming, where the baby is making strange movements of the upper limbs or the lower limbs, and it feels like he's trying to swim or he's trying to cycle or he's just trying to rotate something. These are actually subtle seizures. Subtle seizures can also present as gaze deviation. So all of a sudden a newborn suddenly fixes his gaze in one direction and he keeps it fixed, and then it relaxes back and it comes back to midline. So gaze deviation. or sometimes it can also present as autonomic disturbances. So the baby is otherwise fine, but all of a sudden he would become pale, or he would become cynosed, or he might stop breathing for a few seconds. And this type of apnea is usually associated with desaturations. Like if you put them on an oxygen monitor, you would see that the sats usually dip down to mid 80s or low 80s, and it is associated with an increase in heart rate. So autonomic phenomena can be a manifestation of subtle seizure. Sometimes they make strange lip movements. We call it lip smacking or chewing like movements. And these are also subtle seizures. So subtle seizures, they are called subtle because it's very difficult to pick them up. Obviously, if somebody is making a chewing movement, it's very difficult that you'll put it on to a seizure, unless and until somebody who is very well versed in these types of seizures and knows that there could be a manifestation of neuronal damage. So by and large, subtle seizures are one of the most common type of seizures seen in neonates, and again can be caused by different phenomena. Most of the time it's hypoxic ischemic injury which causes these type of seizures. The second type of seizures that you can see in the neonates is the tonic seizures. Now tonic seizures actually means that the tone suddenly increases. And it's not a generalized increase in tone, it's usually a focal increase in tone of some. So suddenly the limbs would become stiff, or the baby would arch back, and usually there is a sustained flexion followed by some extension, and then slowly and gradually the baby becomes relaxed again. And usually tonic seizures are caused by interventricular hemorrhage. This is more common in premature neonates, or it is caused by kernicterus, which is basal ganglia, or neuronal damage caused by hyperbilirubinemia of the neonates. The third type are the clonic seizures. Clonic seizures are usually manifested by brief rhythmic jerking of a part of the body. So you could see like there is brief jerking of the wrist, or there might be brief jerking of the upper arm. It could be focal if just one arm or one wrist is rhythmically jerking, or it might be multifocal where you would see that one wrist and one leg is twitching, or both legs are twitching, or different parts of the body are twitching at the same time. But again, it's not like the whole body is twitching, the different parts are twitching in tandem, and it's usually seen in hypoxic ischemic encephalopathy. The fourth one are the myoclonic seizures, which usually have got a poor prognosis. These are sudden, shocking, jerky movements of a wide groups of muscles. So all of a sudden, the baby, has got a sudden violent jerk, like he might jerk like this, and then slowly relaxes back. And as I said, the prognosis is usually poor because it might be associated with infantile spasm West syndrome, which usually progresses on to Lennox-Gastaut syndrome, when the other types of seizures, they also kick in at a later stage. But usually these types of seizures, myoclonic seizures, are caused by developmental defects. So usually they might be syndromic, they might be having so many problems at the same time. So to summarize it, the clinical form of neonatal seizures are four types. As I said, subtle seizures, which are the most common, then tonic seizures, clonic seizures, and myoclonic seizures. Subtle seizures have got the most good outcomes. If in an exam you are asked, subtle seizures have got the most good outcome, while myoclonic seizures have got the poorest outcome in terms of if you are talking about later neurological prognosis. Okay, moving on. It's also important to differentiate between neonatal seizures and those things which mimic seizures, because sometimes some movements, abnormal jerky movements, might be mistaken as seizures, though in fact they are not seizures. And the important one of those is jitteriness. The other thing is excessive startle responses, like suddenly there is a loud noise or something and the baby startles, look like some myoclonic jerk, though in fact it is not, it's just a startle. It could be sometime an excessive startle response as well. In that case, you might have to look for Tay-Sachs disease as you anyhow. And the third thing which can mimic a seizure is benign sleep myoclonus. of neonates. Again, it only happens during the sleep. It never occurs during the awake state. So it's important to ask if a child has got a history of seizures, and if they are myoclonic like seizures and they only occur in sleep, even if they have video recorded it and it only occurs in sleep, it never occurs in the awake state, then you should understand that this is benign sleep myoclonus. It's got very good prognosis, usually resolved on its own in a couple of months or years. Now, how do we differentiate clinically if an activity is a seizure or it's a non-seizure, like jitteriness or startle response? Number one, seizures are always stimulus sensitive. Sorry, they are never stimulus sensitive. So it's not like something would provoke a seizure. It happens on its own. Like subtle seizures would start on its own. It's not like you tickle the baby and he would start having a like sort of a jerky movement. While the jitteriness or non-epileptic movements, they are stimulus sensitive. So if the legs are gently stretched or the child is stroked and it leads to jitteriness, then it's most probably not a seizure. Similarly, as far as suppressible, whether the seizure can be suppressed by holding that particular limb, again, whether it responds to that or not, again, this is a sort of a differentiating factor between seizure and a non-seizure. So if a child has got a jerky movements or like, let's say, abnormal rhythmic contraction, and if you hold that part of the limb or that part of the body and it stops, then it's probably a non-seizure. But if it's still seizing, if still has got jerky movement, then it's most probably a seizure. So it's not suppressible in the form of in case of seizure, while it would be suppressible if it is a non-seizure. Then autonomic changes. Autonomic changes are always present in case of seizures. So a child heart rate might go up and the heart rate might go down. There might be a vasomotor phenomena, like in the form of pallor, gray color. Sometimes they might even become cyanosed, while it never occurs during the non-seizure activity. Similarly, eye movements like conjugate deviation of the gaze is usually present in case of seizure, while it is absent in case of non-seizure. So these are some of the things that you should keep in mind if you are not sure whether this is a seizure activity or whether this is a non-seizure activity or a seizure mimic in the form of a startle response or a simply jitteriness, or you think it might be even benign sleep myoclonus. So these are the important things to keep in your mind, and that's how you can differentiate between whether the probability of a seizure activity is high or whether there is a high probability of a non-seizure activity. Okay, moving on. How do we approach neonatal seizures and its management? So let's say you are seeing a baby who has got focal rhythmic jerking movements of the body, and let's say it's occurring intermittently, and you try to suppress it, it doesn't get suppressed, and you think that the probability is high that it is a seizure. Now, what to do about it? Now, it's very important to take a thorough history and do a very thorough physical examination. In history, you should ask about when did the seizure started, what was the sort of the environment in which the seizure started, and how long has been their duration, what has been the associated features. So you ask whether the baby changes color, whether he stops breathing, so on and so forth. So, and at the same time, you would also take a thorough antenatal, perinatal, and postnatal history, because it's important certain events which have occurred during the antenatal period, like mother acquiring an infection and then it being transmitted to baby in utero. Again, you can only pick it up through a thorough antenatal history. Perinatal events are also very important. So prolonged rupture of membranes, any infection in the mother at the time of delivery, similarly in difficult labor, whether there has been any instrumentation at the time of labor, so on and so forth. And similarly postnatal history. So if when the baby is born, did he require any resuscitation, did he cry immediately, then when did he develop jaundice, how severe was the jaundice, did it require any phototherapy or any exchange transfusion. So all these points you must take in history to get a clue that what could be the reason for these types of seizures. So again, I would reiterate here that a good history is very, very important. You should also take a family history of seizures, because in certain cases, if there is a family history of seizures and the baby is otherwise fine, neurologically, your examination doesn't show you anything, the history is also fine, then you can be thinking of benign familial neonatal seizures, again, which has got a very good outcome, very good prognosis, and usually goes away on its own without any treatment. When we talk about examination, a very thorough neurological examination is a must. Some parents usually they are clever enough to video record any seizures, so you ask them if they have recorded the seizures, because that would help you. If the baby is not seizing in front of you, at least you can have a look at the video, and that would give you a clue whether this looks more like a seizure activity or you think it's not a non-seizure activity. So thorough neurological examination, where you would look at the head circumference, you would look for any dysmorphic features, you would look at the newborn reflexes, the tone and power, and the cranial nerves, and again some of the associated features in the examination of the other systems. Again, so the history and the physical examination, again, when you add up the points, so that can give you an idea. If you've got a good understanding of pathology and underlying pathological processes, then it can guide you towards the clue. Now coming down to the management. Now, neonatal seizures, if they are occurring repeatedly and they are not stopping, so let's say if there are more than 3 seizures per hour and they're occurring continuously, then obviously you need to do something to stop the seizures. Now, before moving on to actually giving the drug treatment of the seizure, it's very important that you always remember your ABC. It doesn't, like, nobody would expect you that you start, okay, what should be the treatment? You say, oh, well, we should start with phenobarb. Well, phenobarb you can give, but it would come later on. The very first thing in any child who has got any type of seizure, whether it's a subtle seizure, whether it's tonic, whether it's a clonic or myoclonic, you always start with your airways. So you will look at the airways, whether the airway is clear or not. So that's the first thing. If the airway is not clear, obviously you have to clear up the airways, put any airway adjuncts, like, do some maneuvers to open up the airway. After that, you look at the breathing. So you will see that what is the breathing, what are the oxygen sats, and if needed, you can give them oxygen. Breathing followed by circulation. So again, in circulation, you look at the cap refill time, you will look at the heart rate, you might even look at the blood pressure and the color of the child, and obviously if needed, you would give a fluid bolus, or you can do accordingly whatever you want to do depending on your findings. Fourth is the disability and exposure. And disability, obviously we look at the glucose level. When you do a simple heel prick glucose level, you would also look at the pupil size and reactivity. You would look for any rashes, any temperature as far as exposure is concerned, because you don't want to miss out any neonatal sepsis. So the first and the foremost important thing are, you start with your ABCDs, E's. After that, then what you will do in the meanwhile, while you're doing D, when you are checking glucose, it's better to take a cap gas, because cap gas is a very simple and a quick method of giving you some important clues as far as etiology is concerned. It is very good in at least excluding hypoglycemia, hypocalcemia, and hyponatremia as a cause of neonatal seizures. It can also give you a picture of the acid-base balance. So in case if the acid-base balance is way off, if the child is acidotic, then you can think of the lactate is high, then you can think of might be an underlying septic process going on, or hyperperfusion going on at the same time, and you can address it with IV antibiotics and giving them some fluid push. So cap gas can be very valuable as the initial investigation, and heel prick would do that. Similarly, when it comes to treatment, remember, we only treat if the seizures are continuous. If they are happening intermittently, we don't treat it. But if they are occurring regularly, as I told you that if it is more than 3 seizures per hour, then obviously you need to start treatment. The drug of choice, if even if they ask you in exams, or somebody asks you what is the drug of choice for neonatal seizures, again, it's a bit different from when we talk about the treatment of seizures in older children, and here the drug of choice is phenobarbital. The phenobarb is the only drug of choice in neonatal seizures. The dose to begin with is 20 milligram per kilogram of body weight. So you start that and you give it IV. If it stops the seizures, well and good. If not, you can give some further aliquots of 10 milligram per kg phenobarb till you reach a total of 40 milligram per kg body weight phenobarb. So you can go up to a maximum of 40 milligrams of phenobarb. Once you have reached the 40 milligram of per kg body weight of phenobarb, then you cannot give any further phenobarbitone. So you have to stop over there. Then you have to move on to the second line drugs. In the meantime, if you have found out that hypoglycemia is the cause, and obviously 10% dextrose is your treatment of choice, you will give 2 mils of 10% dextrose per kilogram of body weight, and you give it as a bolus, and then you follow it up with a continuous 10% dextrose solution in the form of 8 to 10 grams of glucose per kg per minute. So that has to be given as a continuous infusion. So it's not like you just correct it with an IV push and then you don't give them a continuous infusion. It has to be supplemented by a continuous glucose infusion. If you find hypocalcemia, then calcium gluconate has to be given. The dose is the same, 2 mils per kg body weight of 10% calcium gluconate. But it's also very important that when you are giving calcium gluconate, you have to monitor the cardiac status of the child. So the child should be put on a cardiac monitor, and you have to look at the ECG when you give a push of 10% calcium gluconate. If phenobarb is not working, you have moved on to the maximum dose of 40 milligram per kg. Then you've got two choices. Either you go for phenytoin in a dose of 20 milligram per kg body weight, or you go for levetiracetam, again 20 milligram per kg body weight. So remember, the keys are quite simple. It's 20 milligram per kg, whether it's for phenobarb, whether it's for phenytoin, whether it's for Keppra. 20 milligram per kg body weight is the standard dose. So if you remember one, you can remember the others as well. Very simple. So phenobarb 20 milligram followed by 10 till you reach a 40. If seizures stop, well and good. If not, you move on either to phenytoin or you move on to Keppra. You will not give both of them. Now it depends on your local hospital policies. Many hospitals still use phenytoin in a dose of 20 milligram per kg body weight given IV, but many hospitals have moved on to Keppra. Keppra is a safe drug. It's a newer drug, and it has also got like comparable efficacy and what I would call benefits as compared to phenytoin. Again, it's the hospital policy. So whatever hospital policy, your hospital policies, you will just follow that. In case, if let's say you give either levetiracetam or you gave phenytoin and it didn't work, let's say, then the question is, what would be the third step? What would be the third, drug in the management of neonatal seizures? In that case, then we go for benzodiazepines. And here it's interesting because in case of managing seizures in older children, we start with benzodiazepines. So we start with lorazepam, or we start with buccal midazolam or rectal diazepam. Here benzodiazepines are used as the third drug of choice, and usually the drug that is used is midazolam. So midazolam, and again midazolam has to be used as an infusion. So the third line treatment is midazolam, which is used as an infusion. And if that is not working, then sometimes we call them refractory seizures, which is not like responding to any types of medication. In that case, we can sometimes try vitamin B6 or pyridoxine. So pyridoxine can sometimes be tried for refractory seizures. It might work, it might not work. But also keep it in mind, if you are suspecting sepsis, if you think that the child is peripherally shut down, he has got fever, he's got like other features which might point towards sepsis, then it's very important to give them IV antibiotics straight away. So broad spectrum antibiotics, which you think sepsis in the neonates can either be group B streptococci, or it could be E. coli, or it could be listeria. So you have to give them a broad spectrum, like which covers the gram positive as listeria and gram negative like E. coli. And sometimes if you think that there might be a chance that some virus might be responsible like herpes, then you have to give IV acyclovir as well. But anyhow, it depends on your clinical judgment and your clinical acumen and what do you think at that point in time. So this is how you treat neonatal seizures. So remember, you will start with the history and thorough physical examination. And again, when it comes down to management, you always start with A, B, C, D, E, and then you move on to treatment only if needed. For continuous seizures, you start with phenobarb, 20 milligram per kg body weight, and then if it stops, well and good. If not, give further aliquots of 10 milligram till you reach the total of 40 milligram per kg. Not working, move on to the second line, which is either Keppra or phenytoin, 20 milligram per kg body weight. Again, if that doesn't work, you'll move on to the third line, which is midazolam infusion. And if still doesn't work, then it depends, like, under the guidance of a pediatric neurologist, then either pyridoxine can be tried if in case of refractory seizures. Also don't forget antibiotics if you suspect sepsis, and if you find hypoglycemia and hypocalcemia, they can be treated accordingly. So this is how you manage neonatal seizures. Okay, once the seizures have been controlled or treatment has been started, now it's important to find out the cause. Obviously, you have taken the history, you have done the physical examination, so you've got a few differentials. Now, based on that differentials, you can do further workup. Again, so how would you start? Again, in the previous section, we discussed that you always start with a CAP-CAS, and CAP-CAS can give you a status of the acid-base balance. It can give you a few initial parameters, like it can give you the blood glucose levels and ionized calcium levels, which can help you in ruling out these two common treatable conditions which are responsible for neonatal seizures. Let's say in case if that is fine, then you have to do a battery of different blood tests, which includes the hematology. We'll be looking at the full blood count. You have to look at the basic blood chemistry, which includes your urea and electrolytes, LFT, your C-reactive protein. You can also look at the precalcitonin levels as an inflammatory marker, and any specific test like blood cultures and other things. Similarly, after that, if you think the child needs EEG, then there are two types of EEGs that can be done. One is the traditional EEG. Now, the traditional one, which is done for 1 hour, another variant of that is the continuous EEG. So continuous EEG, which is done for a couple of hours, and it's usually associated with the video recording of the events as well. So we also call it the video EEG, and there are around 20 electrodes which are put on the different parts of the scalp, and the recordings are taken at the same time, and that's one of the best methods to do an EEG. But these days in neonatal intensive care units around the world, there has been a trend to use what we call as amplitude based EEG. Now, amplitude based EEG is a simple one because you just need two electrodes which are placed on the centrotemporal regions of the scalp, and instead of 1 hour or 3 hour EEG monitoring, you can monitor the child for more than 24 hours. So it is very much operator dependent, though it's not that sensitive as is your continuous EEG, but nevertheless, I mean, in experienced hands, you can pick up a lot many EEG abnormalities on the amplitude based EEG as compared to the continuous one EEG as well. The initial investigation of choice in babies, in newborns, is cranial ultrasound, because the anterior fontanelles is open, so you can put a ultrasound probe and you can look at, and especially it's quite good in picking up intraventricular hemorrhage. Obviously, you can do lumbar puncture if you think that an infective process is going on, if you suspect meningitis. And then, if needed, this can be followed by higher tests like MRI or CT if you are suspecting anatomical defects inside the brain, like neuronal migration defects or any other problems, because that will give you a very detailed assessment of the brain, different regions of the brain, and subtle abnormalities can be picked up. Those abnormalities which the ultrasound can't pick it up, obviously it can be picked up by MRI, because MRI gives you a very detailed anatomical picture of the brain and associated organs. Also remember that in contrast to older children, where if we start treating them, we usually treat them for some time and then we taper them. Remember, we have to keep them seizure free for at least 2 years, and then gradually reduce the dose till we stop them. So the thing is that in older children, the treatment has to be continued over a prolonged period of time. In neonates, it's not the case. In neonatal seizures, if the seizures have stopped, so once you gave them phenobarb, the seizures have stopped, or you gave them anything else which stopped the seizures, and your neurological examination is normal, then at the time of death, you just stop the phenobarb. You don't need to taper down the dose, you just stop it right away. And the child can be discharged without any phenobarb. So this is in contrast to older children, where once you start them on anti-epileptic drugs, then it has to be given for some time and then gradually tapered off. Now, this tapering is not done in case of neonates, provided if they do not have, again, that's a condition associated, provided they do not have further seizures, number one, and number two, neurological examination is normal. So this you should remember. Now let's do a few short cases just to consolidate the theoretical aspect that we have learned in this particular lecture. So we start with a 6-hour-old baby. Let's say who's got a bit of hypotonia as well, and he develops, the mom says he developed gaze fixation. So he just like, he's fixed gaze in one direction, and he does that like occasionally, and he's got some cyclical movements of the arms. So mom brought him, she's very much concerned that something is happening with the baby. Obviously, these types of movement where the gaze fixes in one direction and cyclical movements, this would be part of the subtle seizures. And the question is, what is the most common etiology of these types of seizures? So remember, subtle seizures are most commonly caused by hypoxic ischemic encephalopathy. The other thing, if you look at it, is just a 6-hour-old baby. The only disease which would give you seizures in the first few hours of life is HIE. Rest of the problems, they would give you the seizures a bit later. So they might start on day 2, day 3 and onward. But hypoxic ischemic encephalopathy is the only condition that would give you seizures within the first few hours. So here, the most common cause of subtle seizures the first few hours is HIE. Case number 2, an 8-day-old baby is brought by a worried mom who has video recorded the baby who has got sudden jerky movements of his arms, and these jerky movements are quite frequently occurring while sleeping. On questioning, when you question the mom, she denies that these types of jerky movements never occurred in awake state. So what is the problem here? So this is actually benign neonatal sleep myoclonus. Because why? Because this is only happening in sleep. These are jerky rhythmic movements which are occurring in sleep. The mom denies that these movements ever occur during the awake time. And this would be coupled with the fact that your neurological examination would be absolutely normal. There would be nothing wrong with the baby. So the reason here is benign neonatal sleep myoclonus. Let's move on to the third one. So a 3-day-old baby is brought by ambulance, is brought by the paramedics because he stopped breathing. So mom noticed a very frightening event. He stopped breathing at home for 20 seconds. Then he came back to life, so started breathing. So again, when he's brought to the, let's say, hospital, during the triage, you find that he's got 2 episodes of apnea. So he's got further 2 episodes where he stops breathing, let's say for 15-20 seconds. And because during triage he's being attached to the monitors, you note that the SATs have dropped to 85%, though they come back to 98-99%. The heart rate increases, let's say, from its base rate of 140, 150 to 195, and that comes down. So what is the type of seizure over here? Now this is a subtle seizure. So we will call it as a subtle seizure. Why it is subtle? Because here you can see an autonomic phenomena. And what autonomic phenomena is here? You can see there is an increase in the heart rate, there is decrease in the respiratory rates, so SATs are dropping. So he's having apnea with decreased SATs, and the heart rate increases. So there is no history of jerky movements here. So remember, autonomic phenomena are also a part of the seizures in neonates. So this is a subtle seizure. Again, the reason could be HIE. Moving on to case number 4, a 16 days old baby who was discharged 4 days earlier after being treated for severe sepsis. This baby was born, he was treated for severe sepsis. He got his antibiotics and he was discharged 4 days ago. So he had a severe sepsis and he had a heart murmur as well. Now after being discharged, he was fine at the time of discharge. Now he has started developing intermittent jerky movements of both legs and arms. So he started like intermittent jerky movements. So he's brought in. Obviously, he's got a bad history, past history, because he was treated for severe sepsis. He got a heart murmur. So you do a quick cap gas to see what's going on. You're suspecting that the sepsis wasn't properly treated. So the pH is 7.35. PCO2 is 6 kPa, sodium 137, potassium 4.1, calcium 0.7, bicarbonate 26.3, chloride 104, base excess deficit minus 2.9, glucose is 7.3. I told you earlier that cap gas can give you very good information to start with. So look at the pH. pH is 7.35, which is normal. I mean, it's at the lower end of the normal, but still it is normal. PCO2 is again within the normal range. 4.5 to 6 kPa is normal. Again, I would call it at the upper range of the normal, but still normal. So you can say, oh, well, fine. It looks like probably the beginning of respiratory acidosis, but then I look at the bicarbonate, that's absolutely normal. So I would take it as a normal blood gas. So this is a normal blood gas. You look at the sodium is 137, which is normal. But you look at the potassium, that's also 4.1. Chloride is 104, that's also normal. But look at calcium. Calcium is 0.7. What that means is that the baby has got low calcium. Now this low calcium, it means the baby has got hypocalcemia. So the reason here for intermittent jerky movements or his seizures is hypocalcemia. So how would you treat this? You would give him 2 mils per kg of 10% calcium gluconate. But if I ask you the underlying reason, so if you see he has got hypocalcemia, low calcium, he's got a heart murmur, and he was treated for severe sepsis. So probably he has got a congenital heart condition, he has got some immunodeficiency, and he's got a hypocalcemia. And if I combine these three together, this becomes a classical case of DiGeorge syndrome. So this baby probably has got DiGeorge syndrome, in which the parathyroid glands are not properly developed, so they develop hypocalcemia. They have got congenital heart problems, which might be because of truncus arteriosus or any type of congenital heart problems, and they have got immunodeficiency, so they develop sepsis or life-threatening infections. So this is a case of DiGeorge syndrome leading to hypocalcemia, which leads to abnormal jerky movements. So a few cases have now consolidated your understanding of the neonatal seizures. So just keep it in mind that neonatal seizures, clinically, if we talk about the clinical types, there are 4 types. Subtle, most common, caused by hypoxic ischemic encephalopathy. Tonic seizures, again, which are usually a sudden increase in tone, so that would be decerebrate or decorticate postures, or like sudden stiffening of a limb. There might be the clonic seizures, which might be focal or multifocal, jerking of the different parts of the body, or it might be myoclonic, where like sudden violent contractions of the body. And we talked about some of the reasons. Hypoxic ischemic encephalopathy is the most common, followed by infections, congenital or acquired, and then metabolic problems and structural brain problems. As far as the management is concerned, always start with A, B, C, D, E. Then remember the drug of choice is phenobarb. Here the drug management of neonatal seizures is very different from the seizures in older children. So phenobarb not working, you move on either to phenytoin or Keppra levetiracetam. If that's not working, you will move on to midazolam infusion. Still not working, refractory seizures, then pyridoxine can be tried. Pyridoxine is not part of the overall protocol, but can be tried. So it's very much, dependent on the choice of the neurologist who is treating these babies, or the neonatologist who's treating the babies. And we discussed some of the cases which have consolidated our knowledge. Yes, as far as investigations are concerned, remember, cranial ultrasound is the initial investigation of choice. After that, you can do continuous EEG. Or if continuous EEG is not possible, then extended periods of time the child can be his electrical activity of the brain can be taped in the form of amplitude EEG, but again it's very much operator dependent. But these days there has been trend of using amplitude EEG in many neonatal intensive cares around the world. And for further higher testing, CT and MRI are the modalities of choice. So this concludes our today's lecture on neonatal seizures. We have discussed the theoretical as well as the practical aspects of neonatal seizures, and we have consolidated the knowledge by discussing a few cases to make you understand that how you should have a problem-oriented thinking. I hope you have liked this video, and if you have liked it, I think I do deserve the thumb up. And if you haven't subscribed to my channel, please do subscribe and press the bell notification icon, so whenever I upload a new video, you are always on board with me. If you've got any questions, queries or comments, you can put it down in the comment section below and I will be more than happy to answer them. So have a good day. Bye bye.